Now let's move forward and go ahead with our discussion of the breast tumors. The first description or the classification that we do is on the basis of whether it is epithelial or whether it is stromal. Now under epithelial, all of you know, remember the terminal duct lobular unit. So there's a terminal duct, means there's a ductal component, and then there's a lobular component. And what are the tumors that are going to come under it? If I divide it into precancerous and cancerous, the precancerous one is ductal carcinoma in situ, and the cancerous one is known as infiltrating ductal carcinoma. So let's do the full forms. The DCIS is said to be ductal carcinoma in situ, and IDC is going to be known as infiltrating ductal carcinoma. Infiltrating ductal carcinoma. Similarly, when I go to lobular, under lobular we have LCIS and we have ILC. And what are these? The LCIS is the in situ, the precancerous form. So that is going to be lobular carcinoma in situ. Lobular carcinoma in situ, and then its other variety, which is ILC, is known as invasive lobular carcinoma. So yes, firstly you've done all the ductal and the lobular varieties. What else do you have? You next have the stromal variety. Under the stroma, you have two. Either it is arising from the intralobular stroma within the lobule, or it is arising from the interlobular stroma. Let me tell you the main ones that you learn. That is, what are the two main tumors that you always learn? Fibroadenoma and Phyllodes tumor. Fibroadenoma and Phyllodes tumor, both of them belong to intralobular variety. So always remember, intra means, what is intra? Intra means inside. Inside means filling inside. So all the FF things are going to be filled inside. Fibroadenoma, Phyllodes is filled inside. Whereas what is interlobular stroma? Things like, which you very rarely come across, like a lipoma, or they say there's a blood vessel tumor, that is an angiosarcoma, or they say something known as, very important, listen to me very carefully over here, myofibroblastoma. What is it about myofibroblastoma that I want all of you to note? So usually if I just ask you in general about any kind of breast tumor and I ask you which gender is it more common in, males or females, all of you will obviously say females. It is more common in females, of course, right? But which is the only tumor which has both male and female equivalence, means that the male and female probability of having the tumor is the same. Equal incidence in both male and female. So see, what did I highlight? Myofibro, God has only given it both the alphabets. God has given it M also, God has given it F also. So that tells me that this is going to be equal in male and female. That's how I learned it. Myofibroblastoma, MF tumor. It is equal in male and female. On that note, let's get going. I'm actually starting first with what you encounter commonly in your clinics, in your OPDs, and those are the stromal tumors. So under the stromal tumors, I'm going to take up the intralobular tumors. I told you what is filling in the lobule. Filling is the FNF, the fibroadenoma and Phyllodes. Let's begin with the fibroadenoma. Now, firstly, what is the clinical presentation? Because when you combine the clinical and the radiology, this is very commonly called as the breast mouse. Especially the radiologists on an ultrasound call fibroadenoma as a breast mouse. So what is a breast mouse about it? Remember, this is going to be a soft to firm lump. This is going to be a soft to firm lump, and the size of course varies from patient to patient, but it is completely mobile. See, that's the reason that I'm calling it a breast mouse, because it slips very easily. It slips very, very easily. So for example, if I'll now depict it. If this is the ultrasound probe and this is the lesion, this fist of mine is a fibroadenoma and this is the ultrasound probe. So as soon as I'll put the ultrasound probe, this will slip away. Then I'll put my ultrasound probe over here, it will slip away. Then I put it here. So it's like a breast mouse. It's like a mouse. It's running from here to there because it's extremely mobile. Remember, because of its mobility, it is known as a breast mouse. So that is the clinical and the radiological description. Also, please remember, radiology shows something known as popcorn calcification in a fibroadenoma. So with that, all of you will also have to tell me that what are the two places where, or which is the other place where I've told you the popcorn calcification. So of course, we can now study what are the popcorns. In fact, at least let's study what are the popcorns that we did in pathology. So when you're talking about popcorn calcification, actually that's a radiological thing. Popcorn calcification on radiology is seen on fibroadenoma. It's also seen in the radiology of something else. Go back to your lung chapter. You have studied it under pulmonary hamartoma. You have studied it under pulmonary hamartoma. So remember, in hamartoma we used to study a hamara thing. Pulmonary hamartoma we used to study hamare paise, hamara popcorn. So I had told you hamara coins meant hamare paise. So it shows you what on radiology? It shows us coin lesion. And then I told you, if I pay for the money, I eat the popcorn. So hamare paise, hamara popcorn. So hamara popcorn meant that it shows you popcorn calcification. That was all hamartoma. Hamartoma was hamare paise, hamara popcorn. So it was showing you coin lesion and popcorn calcification on a pulmonary hamartoma radiologically. These were all the radiology popcorns that you had to know. Now you will ask me, what about the pathology popcorn? So where do you see the popcorn RS cells? I've already given you a hint by saying that you were seeing popcorn RS cells. RS basically means Reed-Sternberg cells. Reed-Sternberg cells are Hodgkin's lymphoma. Which Hodgkin's lymphoma? Nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL. Nodular lymphocyte predominant Hodgkin's lymphoma shows you popcorn RS cells. So remember these three popcorns. One is fibroadenoma, pulmonary hamartoma. These two are radiologically. Popcorn RS cell is pathology. Coming all the way back. So yes, we have discussed the popcorn calcification, the breast mouse. Now talking about something new that has been added in Robbins, and what is the molecular alteration. There's a MET12 gene. This also requires a little bit of extra information here. Please remember, MET12 is associated thrice in pathology. I will teach you MET12 gene 3 times. All the 3 times I will tell you, that is, I have learned it as, see, in US most of the people practice family medicine. So I have learned MET12 as family medicine. So med for medicine and family, basically all the FFF things are gonna be family medicine. Means firstly over here you're talking about F for fibroadenoma. Shortly after I'm gonna teach you another F sound tumor, that is going to be a Phyllodes tumor. And after that, when you go all the way to the uterus, in the uterus you will study fibroids. And in fibroids is nothing but leiomyoma. That also shows you the MET12 mutation. Always remember this. Always and always remember family medicine. Family medicine means that all the FF things will remind you of MET12 gene mutation. Coming to the next part that has been added in Robbins, is there any drug associated with bilateral fibroadenomas? Means there are going to be fibroadenomas happening in multiple fibroadenomas happening in both the breasts, and that drug is cyclosporin. Again, something that is added, so given to patients after, say, transplantation. So cyclosporin can cause bilateral fibroadenoma. So quick revision: clinically it's very, very mobile. You call it a breast mouse. Radiologically it tends to show you the famous popcorn calcification. Molecular family medicine, so MET12, and the drug which can cause bilateral fibroadenomas is cyclosporin. Now moving forward and going and talking about, if this patient came to you with a breast mouse kind of a lump, what is the first thing that you must have thought of doing? You would have thought of doing an FNAC. You will put a needle into it. Hai na? So what are you going to get into a needle? Number one finding is going to be the staghorn clusters. The staghorn clusters of cells is what you are going to see over here. So very nicely you can visualize the staghorn clusters present over here. Number one. Number two, you can also see, so staghorn, before that, what is staghorn? Staghorn is like horns of a stag or a deer horns, right? So that is a staghorn. So this looks exactly like the horns of a deer only, for that matter, right? Apart from that, can you see the background has these single blue dot color cells? What are these? These are said to be the bare nuclei. Let me tell you, these are said to be the bare nuclei. What do I mean by the bare nuclei? What is bare about them? Normally when I draw a cell, how do I draw a cell? I always draw a cell with pink color cytoplasm, and then I say there is a blue color nucleus. When I say bare nucleus, only nucleus, bare means no clothes around it, right? So I am going to remove the cytoplasm around it. What is a bare nucleus? Just the blue color dot is seen. Basically, the cytoplasm is stripped off. The cytoplasm is going to be stripped off. This is only for your understanding. Most of the students just mug it up, okay, what this is bare nucleus. But what is bare nucleus? Now you know. So remember, there's number one, a staghorn cluster, and number two, there are bare nuclei that are present. That is what you see on FNAC of fibroadenoma. Guys, that reminds me, there are a lot of staghorns that you have to know. Having said that, there are a lot of staghorns that you should be remembering in pathology by now, and you've read it in a lot of other places, so we'll quickly revise. Where do you see the staghorn clusters on FNAC? That you've already known. Staghorn clusters are seen on fibroadenoma. Other than that, where else do you see the staghorn calculus? Of course, it is seen in the kidney, but what is the other name of the staghorn calculus? It is known as the struvite calculus. And what is it made up of? It is made up of the triple phosphate. That is the composition of the staghorn calculus, triple phosphate. Triple phosphate. Then next, where do you see staghorn blood vessels? Go back to the blood vessel chapter. You see staghorn blood vessels in a condition called hemangiopericytoma. Lastly, in hematology, where do you see staghorn megakaryocytes? So we had already studied SET, that staghorn megakaryocytes are seen in a disease called essential thrombocythemia. They are seen in a disease referred to as essential thrombocythemia. These are all the different staghorns that you should be knowing for your pathology. Of course, when you go to hemat, you will study the megakaryocyte and this entire list would be completed. Coming back, when we are in FNAC, yes, FNAC of fibroadenoma shows you the staghorn clusters, but this was FNAC. What if you do a surgery, a biopsy and remove it? If you remove it, so what would you see on a histopathology in a fibroadenoma? So this on the left is referred to as an intracanalicular fibroadenoma. This is referred to as an intracanalicular fibroadenoma, and the one on the right is referred to as a pericanalicular fibroadenoma. How do I differentiate between them? See, you will have to look at the ducts. Can you see the ducts over here? They are all compressed. See, normally a duct is supposed to look open like this, round like this. Here I'm saying the duct is compressed. So please remember that in the way you write I, intracanalicular, the ducts are also like I. They are going to be compressed ducts. They are going to be compressed ducts. That is how I learn. So they are compressed like an I over here. That is the way of learning it. On the other hand, if the way you write P, how do you write P? P looks like open. P looks like open over here. So how are the ducts going to be? The ducts are going to be open. There are going to be open ducts that you notice, and you can see the same in the picture. You will see a lumen. They are definitely open out here. So is that easy to learn? Intracanalicular, I for I, and pericanalicular, P for P. In intracanalicular, the ducts are also going to look like an eye. All the ducts are compressed like a slit. Whereas in pericanalicular, all the ducts are open like a P. But tell me, from patient point of view, which is better and which is worse? Remember, this is only a histopathology finding. It has no patient prognosis difference. Only for pathologists, the prognosis of the patient shall remain the same. Prognosis of the patient shall remain the same in all these situations. So whether I report it as pericanalicular or intracanalicular, for the patient it's the same. So now tell me, till the time I'm talking about fibroadenoma, all of you are not very worried because it's a benign tumor, but now I'm going to make you a little worried because I am going to add some complex features into it. So when do I say the fibroadenoma has become complicated? It has become a complex fibroadenoma when I have three things in it. Either it has a cyst formation in it, which is more than 0.3 centimeters, or it's got some kind of metaplasia change like apocrine change, or it's got some sclerosis. So please remember that if a fibroadenoma becomes complex, that is how I have learned it. It might be useful for you also. So the way you write complex, the rest of the story is in front of you. C is going to tell you that there is going to be some kind of a cyst that is formed. P is going to tell you that there is some papillary apocrine change that has occurred. Papillary apocrine change, and the way you write complex, X sounds like S, right? So complex. So finally, if there is a change known as sclerosing adenosis, then also we put it under complex fibroadenoma. So the name most of the times is so nice and explanatory. So C for cyst, PL for papillary apocrine change, and XS for the sclerosing adenosis. That is complex fibroadenoma. This comes under what criteria? This has now started showing you complexity. So it's something to worry about. You have to keep the patient under follow-up. On that note, one tumor of the stroma is done, fibroadenoma is done. Now I'm going to move on to the second tumor, and that is the Phyllodes tumor. What you already know about Phyllodes tumor is the genetics, because I told you some family medicine right now, mnemonic, the MET12 gene mutation, that you already know. But other than that, I'll tell you one of the most common genetics that you have is gain of the first chromosome, that is 1q, and the TERT gene mutation also that is reported. This is unfortunately a little bit of ratta rote learning that you'll have to do over here. There's gain of chromosome 1 and there is TERT mutation that is seen. Now, what was it earlier known as? That will solve a lot of confusion. You know, earlier Phyllodes tumor was known as cystosarcoma phyllodes. Now let's try and break the term in both the places. Whether I call it Phyllodes tumor or whether I call it phyllodes, what do I mean by the term phyllodes? Phyllodes means phylum and phylum means leaf. Phylum refers to leaf. So basically this is a leaf-like tumor which you all can very well visualize over here. So what is making it a leaf? Actually, what is all of this that is present from here to here? What is all this? Guys, this is the stroma. It's the stroma which has undergone a lot of overgrowth. This is the stromal overgrowth. So that stroma has made it into a leaf. So phyllodes word I've understood, but earlier they used to call it cysto, means there could be a cyst, okay, but they used to call it cystosarcoma. So now as soon as I use the word sarcoma, the question that you would ask me is it always cancerous? Is it always malignant? So now my answer is no. Phyllodes can be benign also, it can be cancerous. Basically, phyllodes may be cancer, may not be cancer, but so that's why I just call it phyllodes tumor. Whether it is benign phyllodes tumor or malignant phyllodes tumor, I shall decide gradually. But if I've labeled it as cystosarcoma phyllodes like they used to do it earlier, this would tell all the students that it is definitely malignant, which is not right. So now you would ask me that, okay, cystosarcoma phyllodes, we will not use that term. We will just call it phyllodes tumor. But how do I decide? We have to know whether phyllodes tumor is benign, borderline or malignant. There are three types of phyllodes tumor, BBM, benign, borderline and malignant. How do you decide? So what was the tumor? Phyllodes is what tumor? Is it an epithelial tumor or a stromal tumor? It's obviously a stromal tumor, right? So everything that you decide is on the basis of the stroma. You have to look at the cells of the stroma. How much cellularity is there? Are they good looking cells or bad looking cells? Atypia. Next, you have to see stromal overgrowth. So how much of growth has happened? How many cells are there? Good looking or bad looking cells? Basically, my focus is only and only on the stromal element. And for benign, borderline, malignant, I say mild, moderate, severe. Mild, moderate, severe. That is how I have learned it. So whether they ask you about the stromal cellularity, or they ask you about the stromal atypia, or they ask you about stromal overgrowth, basically any word regarding the stroma asked to you, your answer will be mild, moderate, severe, mild, moderate, severe. But don't you think what I find mild, you might find moderate, and vice versa? Everyone has different mild and moderate definitions. So there was a lot of discrepancy that was happening here. They said, give us a definitive criteria which everyone can count. So if I have to count the mitosis, I will tell you, okay, I found 4 mitosis. How many did you find? You will tell me a number. It won't be mild, moderate. So then they divided mitosis per 10 high power field. Anything less than 5 was benign. 5 to 9 was borderline, and 10 or more than 10 per 10 high power field was malignant. So simple. As I say, we divide it into benign, borderline and malignant. Less than 5 mitosis, 5 to 9 mitosis, and 10 or more than 10 per 10 high power fields. So finally, if I ask you, when will you label it as malignant? When it crosses 10 per 10 high power field. Let me tell you, this will be a very important thing which will help you analyze. There are two tumors which have the same mitosis cutoff. If you are talking about malignant phyllodes, at what cutoff do you call it? Mitosis, how much? Mitosis should be more than 10 per 10 high power field. Then I'll call it equal to more than 10 per 10. That is malignant phyllodes. Do you know? In the uterus, when you study leiomyosarcoma, that also has the same cutoff of mitosis, 10 per 10 high power field. These are the only two mitotic related questions that they ask you in the paper. Mitosis cutoff related questions. Dono ka cutoff is 10 per 10 high power field, whether malignant phyllodes or a leiomyosarcoma. with which, if I go back to my classification, we have definitely wrapped up a very important aspect, and those are the stromal tumors. I hope you remember whether I spoke about fibroadenoma or phyllodes, both of them were in the lobule, filling the lobule, intralobular, whereas interlobular were lipoma, angiosarcoma, and myofibroblastoma, out of which M and F, that is myofibroblastoma, M and F were having male-female equal preponderance. Now we'll move forward and talk about the different breast tumors coming under the epithelial categories. We'll divide it into ductal and lobular. Before that, we'll first discuss the risk factors and the genetics. First, let's begin with the risk factors of breast cancer, because not only will this help you in your pathology questions, but also in solving a lot of surgery points out there. So we've divided the risk factors into two categories. You can see the first one over here is familial. Whenever I say familial, there'll be a lot of genetics that will be involved. Another one will be non-familial or sporadic. So let me start with the sporadic one first, because it's quicker to finish off. So firstly, you know that it is seen with advancing age, and you're seeing all the things which are exposed, or you are seeing increased estrogen exposure. Means that whenever someone has early menarche, or a female has early menarche and late menopause, that automatically increases the estrogen exposure in her life. So these are two factors which are contributing more. Apart from that, also this is associated with nulliparity. It is associated with lifestyle and dietary changes. For example, obesity, high fatty diet, and sedentary lifestyle. Also another lifestyle, that is smoking. These are the risk factors with which breast cancer is associated when it comes to the non-familial aspect. But when it comes to the familial aspect, means genetics, now there is a table that has been added in Robbins, which we are going to talk about. And I think everyone knows the two most famous genes, BRCA1 and BRCA2. So actually, I'm going to start off the story from there only. We'll be starting with BRCA1 and BRCA2, because together you can see that when I'm dealing with familial breast cancers, how much percentage are they together comprising? Approximately a 90%. BRCA1 is the most common, BRCA2 is the second most common. So together they comprise of 90% of the familial breast cancer, because after this all the other genes will be 1%, 5% and so on. On that note, also please remember and recall from your neoplasia chapter that BRCA1 was present on chromosome number 17 and BRCA2 was present on chromosome number 13. And what were they responsible for? I think this everyone remembers. BRCA, the name only suggests that first, of course, breast cancer. But other than breast cancer, they can also be associated with ovarian cancer. They can also be associated with prostate cancer, right? Especially BRCA2, I have taught you in prostate cancer also. But what I want to tell you additionally over here is that which of these is associated with male breast cancer. And that is something that you need to know. BRCA2. Remember, BRCA2 is associated with male breast cancer. There are not too many male breast cancer things that you would have to know when it comes to pathology or surgery, but this is definitely one of those. Remember, male breast cancer associated with BRCA2. Okay, moving forward, these were all the main ones, 90%. What are all the ones which are less than 1%? You can see P53. And I think everyone remembers from their neoplasia chapter again that P53 gene mutation is known as Li-Fraumeni syndrome. And go back to your genetics. Li-Fraumeni syndrome was what inheritance? It was an autosomal dominant inheritance. So Li-Fraumeni syndrome, autosomal dominant, P53 mutation, the overall percentage of familial breast cancers is very less. And what all does this syndrome have? So if you go back to your neoplasia, you will remember the story of BB tumors. Means these patients have breast cancer, they have brain cancers, they have bone cancers, and they have blood cancers. So breast, brain, bone, blood. When a family has BB tumors, when a family has these BB tumors running in them, that is when you would suspect P53 mutation, Li-Fraumeni syndrome. How much percentage? Very less, less than 1. However, guys, if someone asks you that what is the most common cause of sporadic breast cancer, the most common cause of sporadic breast cancer, or the most common genetics, that would actually be a better thing. Most commonly associated with sporadic breast cancer, you would say P53. So what's the difference? What's the difference over here? Because whatever I was teaching you up till now was familial breast cancer. So when it's running in the families, then P53 has a very low chance. It has only less than 1% risk of familial breast cancer. But when it's not running in the families, when it's sporadic, then P53 is the most common. So if I go back to my sporadic, I can add genetics over here as well. I can add genetics over here as well, and in the genetics over here, the most common genetics of sporadic breast cancer will be written as P53, means it's not running in the family. But when it is running in the family, it is only a less than 1%. And what syndrome? Li-Fraumeni syndrome. Moving on to the next, there are a lot of others less than 1% ones which I'm dealing with familial breast cancer. So most of these you have read in elsewhere in pathology. Let's go ahead. Let's talk about P10 gene. P10, I think everyone knows, the name only tells you. P10 is present on chromosome 10. And do you remember a syndrome that it used to cause? It used to cause the very famous cow-den syndrome. And how did we learn it? We had learnt it as 10-10-den. That was our way of learning it. 10-10-den. So 10-10-den, cow-den syndrome. And what all does it have? I had made you a mnemonic also, that the mnemonic of this was P10 only, where N was standing for endometrial cancer. N was standing for endometrial cancer. T was standing for two things. Number one was thyroid cancer, and another T that you had was tricholemoma. Another T that you had was tricholemoma. And lastly, P was again for two things. Firstly, you studied this in the intestine, so it causes polyps. And now, of course, you're studying it in the breast cancer chapter. So the P will be changed into a B, and it is also seen with breast cancers. That is the mnemonic for cow-den, 10-10-den. P10, chromosome 10, cow-den, and the mnemonic is also P10, polyps and breast cancer, thyroid cancer and tricholemomas, and endometrial cancers. Moving on to the next, STK11. This also causes a very less percentage, less than 1. These are all less than 1% things. Do you remember where was STK11? I'll give you a hint. You'll have an 11-year-old boy with 11 STK mutation. What was that 11-11? That was known as the Peutz-Jeghers syndrome. The Peutz-Jeghers syndrome, that is how you had learnt it, that in Peutz-Jeghers syndrome, the age is 11, STK11. But now, obviously, I'm not talking about an 11-year-old boy. I'm talking about what other cancers, if it occurs in females, what other cancers are they at a risk of? So remember, yes, this has been associated with breast cancer. This has also been associated with colon cancer now. Both of these are very well known with Peutz-Jeghers. Next, CDH1. Again, you studied it in neoplasia. I'll remind you the other name. CDH was derived from E. cadherin. So I told you pick up the alphabets in E. cadherin. Pick up the alphabets, that is C, D, and H, and you're going to get E. cadherin out of it. So when is E. cadherin mutated? Of course, there's going to be a breast cancer. But which breast cancer? There is ILC, invasive lobular carcinoma. The breast cancer that I'm talking about is invasive lobular carcinoma. In fact, I want all of you to recall one thing with me. Do you remember I told you that E. cadherin was something that was holding the cells together? It was your glue. If you guys remember, E. cadherin was like a glue. So I told you when the glue is lost, or in other words, when the E. cadherin is lost, if the glue is lost, there are going to be what tumors? Golu tumors. That is how we had learnt it. Now, glue is lost, Golu tumors occur. What is the Golu tumor? So, Golu means there is going to be invasive lobular carcinoma. So, in breast, you know which ductal or lobular. So, Golu will tell you lobular carcinoma. And the G will tell you gastric cancer. So, there is diffuse gastric cancer. There is diffuse gastric cancer. So, remember, when the glue is lost, the Golu tumors occurs. Having said that, now coming back, we are done with CDH also. E. cadherin loss is also done. The table is not over. The last part of the table is this. First, I'll cover up ATM and check 2, because then I'll come to PAL B2, which is an update. So firstly, ATM. What is ATM? ATM stands for ataxia telangiectasia. So ATM gene mutation, which almost has a 5% frequency, those are associated with ataxia telangiectasia. Those are associated with ataxia telangiectasia, and the name itself is enough. The patient will have ataxia. The patient will have angiectasia. Angiectasia means blood vessel dilation. Ectasia everywhere means dilation, right? Okay, so that is ATM gene. And what is CHEK2 gene, which is a very, very, very important question. Remember, CHEK2 gene is associated or is a question of radiation-induced breast cancer. So radiation-induced breast cancer is something that is going to have CHEK2 gene mutation, and they really, really love asking you this question. Radiation-induced breast cancer. How do I learn it? So I learned it that, as a healthcare professional, what we are most negligent about is we always are concerned that the patient should not get overexposure to radiation and other stuff, but we are never bothered about what exposure to radiation we are having when we are in a hospital. So you guys have to make sure that as healthcare professionals, you and all your staff around is taking precautions while you are entering a radiology department, that you should not get overexposed to radiation. So yes, as I always say, keep a check on your radiation exposure. Keep a check on your radiation exposure. So now if they ask you, radiation-induced breast cancer is caused by which genetic mutation? The check was lost. CHEK2 mutation. Now coming to the last one, what is PALB2? Although it comprises of very less than 1%, but it's very interesting, because now remember that the way you write PALB2, the cancers that the patient can have because of this is a prostate cancer. Then another P I can see over here. This means the patient can have pancreatic cancer. And I can see a B over here. So obviously the chapter is breast. So the patient can have breast cancer, pancreatic cancer, prostate cancer, and breast cancer. That is what has been mentioned. But in all of them, I have written something called monoallelic losses will occur. This means there must be some other thing known as biallelic losses of PALB2. So what is allelic? Everyone remembers from your genetics that we have two alleles. One comes from mother, one comes from father. Two alleles in every gene. So PALB2 has two alleles, one from mother, one from father. If one gets deleted, one loss is there, that is going to result in all these cancers. But if there is a monoallelic loss, this can result in Fanconi anemia. So always remember that the next thing that you have is going to be anemia. The last alphabet which I was not talking about, and that was Fanconi anemia. But keep in mind that in cancers it is one loss, because now I'll tell you a sad story of the society. The sad story of the society is that no one stands with cancer patients. The support, mental, financial, that a cancer patient gets, unfortunately still very less in our society. So that very, very sad situation also becomes our methodology of learning. That is that cancer patients left alone. Alone means single loss, left single. So left single, left alone. Monoallelic losses are seen with cancers, and Fanconi anemia shows you full loss. That is how I've learnt it. Fanconi anemia is going to show you full loss, means there is going to be a biallelic loss. On that note, all your familial breast cancer and genetics are done. If I had to do a super rapid revision, majority of these are associated with BRCA1 and BRCA2, almost 90%, but the male breast cancer is to do with BRCA2. After that, you have a lot of minor ones, like you have P53, you have the P10 gene, which was causing Cowden syndrome. You have STK11. You have cadherin, that was the glue, and particularly this cadherin causes invasive lobular carcinoma. Then you have a new gene called PALB2. It causes breast cancer, but which loss? Mono or bi? It causes monoallelic loss. That is very, very important. Then you have two other genes. One is the ataxia telangiectasia ATM gene, and then you have CHEK2. And what is CHEK2? Which kind of breast cancer does it cause? It causes radiation-induced breast cancer. So in this slide, nothing new that I've told you, but I've told you the questions. For male breast cancer, BRCA2. For PALB2, monoallelic loss. For invasive lobular carcinoma, E-cadherin. And for radiation-induced breast cancer, CHEK2. The most expected 4 questions. Having discussed all the risk factors, now we can jump into our cancers. And if you go back to your basic classification that we had studied, if you guys remember, I used to tell you that the basic classification includes ductal and lobular. So here you go. You have a ductal cancer and you have a lobular cancer. And in ductal cancer, I told you, these are the two things that I will teach you first. ductal carcinoma in situ and infiltrating ductal cancer. So here I start with ductal carcinoma in situ. So look at the word. Obviously, this tells me the origin. It's going to be from the ducts. But till the time I write in situ means I am dealing with a pre-cancer situation. The full cancer has not occurred. So tell me one thing, guys. Whenever I was drawing a duct, how many layers was I drawing? I used to draw one layer on the inside, and that layer on the inside was known as what? That layer on the inside was the epithelial cells. So will the epithelial cells be present? Yes, and that's the kind of precancerous part. So not only are they going to be present, but they are going to be present in a lot of abundance. They are going to be present in a lot of abundance, almost filling up the ducts. They would be there. But do you also remember that there was some cell at the periphery I had told you, known as the myoepithelial cells? They are also here. Here you have the myoepithelial cells in front of you. Then how is it a precancerous stage when everything is there? Please remember that till the time these are there, I am still in precancer. Remember I told you the story of a lizard. Till the time you're seeing the lizard, obviously lizard is scary, but till the time you're seeing it, you're still comfortable. Once it vanishes, you don't know where it has gone. That is when the real panic attack happens, right? So till the time I'm seeing the myoepithelial cells, things are fine. More than that, around every duct we have something known as a basement membrane. Around every duct we have something known as basement membrane. So I realized that everything is visible. The myoepithelial cells are also present as of now. The basement membrane is also present as of now, because when these two things are gonna vanish means proper cancer has occurred. When will I know that pre-cancer has changed into cancer? You will say that whenever over here your number one basement membrane goes away and number two these myoepithelial cells go away, that is when cancer will occur. But till the time they are here, the full cancer has not occurred. I am still in the pre-cancer stage. So remember, for cancer, the myoepithelial cells will go away and the basement membrane will be broken. So that is the later part of the story. Right now, I'm interested in ductal carcinoma in situ. The in situ part means everything's still here. Myoepithelial cells are here, basement membrane is here, and now let me look at the types. Look at these different types, guys. You have something known as solid DCIS. So for everything, you won't get a picture. Some things you just have to learn theoretically. Solid DCIS means that the duct is solid, full of cells. Solid means full of cells. Then you have something called papillary. Papillary means that the duct is showing you the cells have made chota papilla. The cells have made papilla. If they made proper papilla, you call it papillary. If they make really tiny papilla, you call it micropapillary. So as simple as that. Either they're going to be filling, the cells are going to fill up the duct, solid. They're going to make papilla, papillary. They're going to make chota papilla, that is micropapillary. So these are no pictures. These are just terms that you have to know. But now I'm going to tell you two for which you get a picture. Comedo DCIS and cribriform DCIS. What is cribriform and comedo? Let's start with comedo. Comedo reminds me of comedon. Comedo reminds me of comedon. Comedon means, so comedo necrosis. Comedon means it's something like acne. Comedon is acne, and all of you know that if you press an acne, press a comedon, some dirty material comes out, hai na? So look at this. You are having a duct over here, and duct has cancer cells. But in the center of the duct, I am seeing some pinkish dirty material. Have a look at this. This pinkish dirty material in the center. This is the necrosis in the center. Just like acne has dirty material in the center, this also has necrosis in the center. That is the reason I compared it with a comedon, or compared it with an acne, that is comedonecrosis. The other DCIS is cribriform. What is cribriform? What do you understand by cribriform? Cribriform means sieve. In Hindi, it's known as channi, the sieve that you use, the channi that you use for making tea, for pouring tea. So it has holes in it. Every sieve has holes in it. So if there is a DCIS with holes in it, I will call it a cribriform DCIS. So remember, these are the two pictures that you have to know. The comedo DCIS and the cribriform DCIS you have to know. But on that note, guys, tell me something. Where all in pathology have I taught you the cribriform pattern? I'll show you the cribriform pattern. Have a look at this. This is the cribriform. This is the sieve that I'm talking about. So the sieve or the channi or the cribriform pattern that you have. So you've read it in 3 places. In the breast, I've told you there is something called cribriform DCIS, ductal carcinoma in situ. In prostate, again, prostate cancer, prostate carcinoma also shows you, but the question comes is, prostate is Gleason pattern, right? So cribriform is which pattern? Cribriform in prostate is pattern number 4, and this is how we had learnt it. We learnt it as cribriform. That cribriform is the 4th pattern, cribriform. Now coming to salivary glands, please remember adenoid cystic carcinoma tends to show you the cribriform pattern. Adenoid cystic carcinoma shows you the cribriform pattern, ACC. So these are the 3 tumors or conditions in pathology where this chunny or sieve or cribriform is going to come up in front of you. Okay, so the DCIS types are done. Now let's move ahead. Let's go from in situ to cancer, to ductal carcinoma, and the first thing I write it as IDC. What is IDC? Infiltrating ductal carcinoma. This is to tell me that not only carcinoma word anyway tells me it is infiltrated, but they want to be double sure. So they've given you a name called infiltrating ductal carcinoma, but they have called it NOS. What is IDC NOS? IDC NOS. NOS means not otherwise specified. Not otherwise specified, or in very simple words, if you want to learn it, no special type. See, every cancer has a conventional classical type, and then there are some tiny variants. Some of them are good, some of them are bad, some are aggressive, some are very good. So there are tiny variants, but they all come out from like the parent tumor. This is the parent tumor. It's not of any special type. It's the usual classical IDC. And if you look at this specimen over here, you can see a breast specimen. It's very yellow. You can see all the fat around it, but then you can see an irregular tumor mass. It's irregular, trying to delineate the margins. So this is the tumor that you have. And if you see, it's got some whitish areas also in the center. Basically, it's very gritty. So anyone who's done vegetable cutting in the house, you know, this is, I remember when I had recently joined my residency, my head of the department had asked me the first question, have you cut vegetables in the house? And you never say no to your HOD. So all of us, whether we had ever even picked up a knife or not, but it's a rule. In your residency, you always say yes to your head of the department. So as soon as the HOD asked us, have you ever cut vegetables in the house? We said yes. So he said, he knew, obviously he was also once a resident. So he knew that we are just saying yes because we wanted to get a good impression on him. So he just told us, well, now I'll get to know within a day whether you've ever done that or not, because cutting pathology specimens, a lot of correlations come to with cutting vegetables. So he said that if you've cut cabbage and you know that sound that comes on cutting cabbage, that kind of a grittiness is what you would feel when you cut a breast cancer. And yes, maybe we had never cut cabbage, but definitely when we cut breast cancer. So for me, it happened other way around. I first learned pathology because till then I did not know how to cook. Not that I know anything good right now also, but still when I later on learned how to cook, that is when I could correlate that this is cutting like breast cancer, this is cutting like a potato. So potato looks very similar to a seminoma. So for me, this journey was other way around. I learned cutting in pathology first and then implemented it into the kitchen later on with whatever little I could do. On that note, so when you cut a breast cancer, it very commonly has that grittiness. It has that cabbage kind of grittiness because there's a lot of calcification. And don't we also see calcification is there, fibrosis is there, and don't we see the same calcification which a radiologist also tells us, right? So yeah, that's a grittiness, and microscopically it sounds like such a big thing, infiltrating ductal carcinoma, but comes down to the fact that it's an adenocarcinoma because duct and glands will always give rise to adenocarcinoma. So that's how simple it comes down to. I will see ducts and glands, but that is when I'm talking about NOS, no special type. Now I'm going to go into some special types, and that includes tubular carcinoma. You don't have to know anything fancy about it. So now we are starting with IDC, but not special types is done. Now I'm starting with the special types. So the first one is tubular carcinoma. Tubular carcinoma shows the presence of regular tubules. Tubular carcinoma shows the presence of regular tubules. So there's a tubular arrangement that is noted, and you need to know the prognosis because it has a very good prognosis. Very, very good prognosis is seen. So a big smile over here. Let's move on to the next type. The next type is quite an important MCQ, so listen to me very carefully. There's something called the mucinous or the colloid carcinoma. So remember, whenever I say mucinous, I have started learning it as mucin and us. Means, firstly I've learned muc for mucin, in for means it's inside the cells also, and out for means it's outside the cells also. So there's a lot of mucin inside and outside the cell. So you know how do we define it? This is a tumor which is said to have pools of mucin, like water. Like water, the mucin is floating around. Pools of mucin are present extracellularly, that is out, and there may be mucin intracellularly also. And I think by now in pathology you all know that whenever mucin is present inside the cell, I call it a cell called the signet ring cell. We refer to it as the signet ring cell. So can this show you signet ring cells? Yes. So can it show you like lots of mucin out and lots of mucin in? So there's like water. Water is, you just imagine you are sitting in a pool of water and you are drinking water. That is what this tumor is. It's got mucin all around it and it's also having mucin inside the cells. So if you have a look at these two pictures now, guys, the first picture on the left is an FNSE finding. And the next one over here, this is a biopsy. So how do I differentiate? One thing that I'll have in common is lots and lots and lots of mucin. So if you look at the background, you can very well visualize that there is a lot of whitish or some fluidy part that is there. But apart from that, what has happened is all the blood vessels got entangled in that mucin. All that blood vessels got entangled in that mucin. So remember, FNSE shows you chicken wire blood vessels. Very, very important finding. FNSE shows you chicken wire blood vessels. And what does biopsy show you? Biopsy shows you again lots and lots of mucin. The mucin is going to be extracellular, the mucin is going to be intracellular, and you're going to see signet ring cells along with it. So now all that I had made you study comes down to two things. What do you see on an FNSE? Chicken wire blood vessel. What do you see on a biopsy? Lots and lots of mucin outside the cell also, inside the cell also, signet ring cells. Coming to how would this present clinically? Please remember, guys, clinically, if there is so much of mucin is like gel. If you guys have touched gel, any kind of gel is never hard. Although I'm talking about a cancer, and cancer is supposed to be very, very hard, stony hard kind of a thing. But suddenly when I have so much of mucin, can this be soft to firm? And can this be mistaken clinically for a benign lesion also at times? Yes, so sometimes there is a clinical and a pathological discrepancy where the clinician was thinking of it to be a benign lump, but my report will go ahead as a mucinous carcinoma and I'll get a call back. Are you sure? Are you sure it's a mucinous carcinoma? And I'll tell my findings. Yes, I saw pools and pools of mucin. Over here also the background is all pools and pools of mucin. The cells are like floating. Look at these cells. They are like floating. So you will see a lot of floating cells. Where are they floating? They are just floating in pools and pools of mucin. On that note, finally, what is the other name? This is known as colloid carcinoma. Total misnomer. It has nothing to do with thyroid or colloid. It's just named so because so much of watery mucinous material is there. So they said colloid carcinoma. That's it. So this is done. Moving on to the next one. After mucinous, we go on to medullary. Medullary is famous for the 3 P's. And what are the 3 P's of medullary? Firstly, when you talk about the margins, medullary carcinoma is said to have pushing margins. Medullary carcinoma, pushing margins. When you look at the cells, they will have prominent nucleoli. So honestly telling you, these are the things you will never be able to identify because you don't have that ability of zooming in the paper. So you will have margins which will be infiltrating and pushing. You will have prominent nucleoli. But what can I actually see? Lymphoplasmacytic infiltrate. You are going to see lots and lots of plasma cells. There is a plasmacytic infiltrate that you need to know over here. So remember these 3 P's. Firstly, you have something called pushing margins, then prominent nucleoli, then you have the lymphoplasmacytic infiltrate. So what can I see in this picture? Again, if I look at this picture, it's very difficult to identify the pushing margins or the prominent nucleoli, but definitely what I can see is that in between, I'm seeing a lot of lymphocytes. I'm seeing a lot of dot, 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 dot. Those are all lymphoplasmacytic cells. You can visualize them over here also, yes? So those lymphoplasmacytic, that blue color dot, dot, dot is very characteristic. Now let me tell you guys one more thing. This lymphoplasmacytic infiltrate actually comes in a lot of places, and I'm going to enumerate the 3 that I have taught you in pathology. When we talk about the LP infiltrate, lymphoplasmacytic infiltrate, firstly, if they mention the breast tumor, you are going to talk about medullary carcinoma. You are going to talk about medullary carcinoma. Second, they talk about the testes or maybe the ovary, whatever is the male, female gender. You are going to talk about seminoma. And you know that, okay, seminoma has lymphoplasmacytic infiltrate, and if seminoma had, then the ovarian counterpart was dysgerminoma. So that also has. Coming to the third thing, they will also ask you lymphoplasmacytic infiltrate in a liver disorder, that is autoimmune hepatitis, shows you lots and lots of lymphoplasmacytes. Now we come to, there is something in hematology. The name of that disease is only lymphoplasmacytic lymphoma. Lymphoplasmacytic lymphoma. And what is it also known as? Lymphoplasmacytic lymphoma is also known as Waldenstrom's macroglobulinemia. So in case you've not studied, you will of course study this in hemat. So the naming is only having lympho and plasmacytes in it. So they will show you lymphocytes also, plasma cells also. So breast में कौन सा tumor? Breast में it is going to be the medullary carcinoma. It has a bad prognosis. I'm not telling you the prognosis alongside, because all of them I'm going to make a table in the end and tell you the prognosis. Okay. Let's move on to the others. The others which you just need to read. There are some other types also known as apocrine carcinoma. There is something known as a metaplastic ductal carcinoma. There's something called a secretory carcinoma, which tends to occur at a younger age. It tends to occur in younger females, not the usual 40 and above. Usually occurs in the younger 20s, and that's the age group. So younger females. And then comes examiner's favorite, inflammatory carcinoma, with the first word being the wrong word. Can a cancer be inflammation? Of course not. Cancer is cancer. So why is the word inflammatory being used? So what happens over here? In inflammatory carcinoma, the tumor cells, the cancer cells are going to spread. How are they going to spread? They are going to spread to the dermal lymphatics. The tumor cells are going to spread to the dermal lymphatics, means they are somewhere trying to go and involve the skin. And that is the reason that the skin has this very famous peau d'orange appearance. The peau d'orange appearance is going to be seen. So you can very well see the peel, orange peel over here. And you can see the skin which is having the similar appearance. Very, very famous surgery question and image that you have, isn't it? So this appearance that you have over here is because the tumor cells, and this was the recent exam question also. This is the appearance that you have because tumor has entered into the dermal lymphatics. That's an inflammatory carcinoma. Of course, in terms of prognosis, the tumor is coming to the skin, it is going to have a poor prognosis. The prognosis is one of the worst. The stage is one of the highest. So remember, it has a poor prognosis. This was all about the ductal cancers. A very quick recap. The first one that I taught you was just no special type. Very, very gritty adenocarcinoma. Then I say let's start with the special types. Tubular carcinoma, very, very good, just showing tubules. Mucinous carcinoma, showing you lots of mucin in and out. And it is going to be a little softer, so it might be mistaken clinically. Next, you have medullary carcinoma. Medullary carcinoma shows you the 3 P's. That is, it has pushing margins, prominent nucleoli, and plasmacytic infiltrate. Then you have others like apocrine, metaplastic, secretory. Secretory occurs in younger people. And finally, inflammatory, which is very, very bad. It looks like an inflammation. The skin might look like an inflammation, but it's not. It is to do with cancer coming into the skin, and that is giving an orange peel appearance. On that note, that we are done with ductal cancers, we can move on to ILC. Invasive lobular carcinoma. But you already know the genetics about it, isn't it? You already know that invasive lobular carcinoma was the loss of that glue, and that was the loss of E-cadherin. And what was the gene for E-cadherin? It was the CDH1 gene. The gene for E-cadherin was CDH1 gene. Now let's go on to how would the patient present. This usually tends to be bilateral and multicentric. It will be bilateral and multicentric. So this means that there's a very high chance that if the female has had an invasive lobular carcinoma of one breast, she has to be kept in follow-up or might be even considered for a prophylactic mastectomy of the other side, because the chances of it being bilateral are quite high. So this is the job of a surgeon and of a pathologist. Whenever I write my report, for example, I got a biopsy from this breast, I got a biopsy of a lesion from this breast, and in this lesion, in this true cut biopsy, I realized it's an invasive lobular carcinoma. So it is my duty, although I know the surgeon will do it, but it is my duty to double check and to confirm that in my report, when I write invasive lobular carcinoma of, say, the left breast, I have to tell the clinician, note, kindly check or kindly follow up and examine the right breast in order to check for bilaterality and multicentricity. It's a rule that we follow in all subjects. Okay, so this is a very important point that you have in ILC. But what did I see under the microscope? What are the features? This is how the tumor cells are going to be there. The tumor cells are going to be present back to back, like army men, disciplined. If you look at army men, they are very disciplined. They'll be standing one behind the other. So that is known as the Indian file pattern. That is like the Indian army, that is the Indian file pattern tells you that these are present. The tumor cells, if you look at them, they are like a row. They are present one behind the other. Look at over here also. No one is going any left, right. They are all following a line, one behind the other. Over here as well, a tinier picture. Wherever you will see they are going one behind the other. That is the Indian file pattern. Secondly, I also want to tell you that these show you minimal desmoplasia. They tend to show you minimal desmoplasia. That means desmoplasia was what? Desmoplasia was fibrosis, right? So whenever the first part of neoplasia, I told you, desmoplasia was fibrosis. Whenever there's a lot of fibrosis, the tumor is very hard. Here, this is not showing you much of desmoplasia. So minimal fibrosis is there. But that's not the only thing. These are just two findings that I've told you. Other than that, you have to know the other two findings more. So what is the third finding? So tell me, is it a lobular tumor or a ductal tumor? The name is telling me it's a lobular tumor. Problem is in the lobular cells. It is not in the ductal cells. Okay, so can you see an innocent little duct in the center trapped? This is a normal duct, and surrounding that normal duct, can you see lots and lots of tumor cells which are surrounding it like a target, like some innocent person has been targeted and all the naughty people are standing, all the the naughty and powerful people are standing and trying to overwhelm him unnecessarily. So remember, these are all the tumor cells which are targeting it. This is known as the targetoid lesion. This is known as the targetoid spread. They tend to spread around a normal duct. Sometimes they will go inside the duct. You know what they'll do? So like for example, if there is one innocent little student and everyone around him is trying to bully him. So this is exactly, there's an innocent little duct and all the cancer cells are trying to bully him. So what will they do? First, they'll all make a group and stand around him. Right, that is the target. They are targeting him. They made a targetoid lesion. Now after that, they might touch him, they might push him, they might start acting violent with him. So basically the cancer cells might say that I want to go inside these normal ducts. They're trying to bully that duct. You know what is that known as? That is referred to as the pagetoid spread. That is referred to as the pagetoid spread. So just imagine this to be a scenario of bullying, which should obviously never ever be done. But yes, you all have seen this around you happening, which you should always stop. But if it happens next time, this is also a tumor coming to your mind. You have an innocent little duct in the center. You have all the bad, naughty cancer cells bullying it around. That is targetoid lesion. If they start pushing that tumor, the innocent duct, or they start infiltrating into it, that is a pagetoid spread. And finally, remember, invasive lobular carcinoma can also show you signet ring cells. And when I say signet ring cells means, what does it contain? It also contains mucin, but stop. Was mucin also present in some other tumor? Remember, it was mucinous, but over there, mucin was in and out and everywhere. Mucinous was in and out, mucin out. That is how we had learnt it. Here, there is only and only tiny, tiny mucin inside the cells. These are all the signet ring cells that you have. So there's only little, little mucin, and sometimes it may be seen, sometimes it may not be seen. In mucinous, it was all about mucin. Here, it is very little mucin that is present. So 5 things that you have to know for invasive lobular carcinoma. Number 1, it shows you the Indian file pattern. Number 2, the desmoplasia is minimal. There is minimal desmoplasia. So I'll put a minimalistic sign over here. Next, remember the bullying story. They will stand around the duct, that is known as the targetoid spread. They will also try to push the duct a little, that is known as the pagetoid spread. And sometimes a finding which you may or may not see, that is the signet ring cells. These were all the things that I wanted to teach you with all the pictures on one place. I hope you will be able to learn this with the genetics, loss of E-cadherin, and the important point, it can be bilateral and multicentric. On that note, ductal cancers done, lobular cancers done. What about a cancer on the skin? Cancer on the skin is known as the Paget's disease. Now, before I start with Paget's disease, this much of information everyone has, that there is a Paget's disease that you're studying over here, which is in the breast. So I'll call it the mammary Paget's. And then there's an extra mammary Paget's also. The same lesion can also happen in the vulva. So now when you go to the vulval tumors, I've taught you the same story over there as well. Apart from that, there is a Paget's disease that's going to occur in the bone as well. But that Paget's is totally different. That Paget's and these Paget's are not the same. So don't confuse it. Keep that totally different. The two same ones are going to be the Paget's of the breast and the vulva. And what does it look like? As I told you, it's going to be looking, the patient might not come to a surgeon. The patient might go to a dermatologist. Why? Because this is going to show you crusting. This is going to show you excoriation. This is going to show you a lot of dermatology kind of lesions. And yes, the patient might also complain of pruritus. So all in all, I don't see anything related to surgery. I see a lot of dermatological problems here. So when this dermatologist tries to do a biopsy from this area, there are 2 pictures that I've shown you over here. So definitely you're going to see the epidermis because you've done the biopsy from the skin. So you're going to see the epidermis. And over here, you can see these empty looking cells. Same way over here also you can see that the epidermis is showing you some empty looking cells, and those are known as the Paget's cells. Those are known as the Paget's cells. So why are they empty? Why are the Paget's cells having a clear cytoplasm? Because now you will remind me of all the stains. Why are the Paget's cells having a clear cytoplasm? Because they can contain number 1 glycogen, that is why it is PAS positive. It can also contain mucin, so it is mucicarmine positive, and it is also known to contain fat. So it is oil red O positive also. As I was saying those things, were these stains coming back into your mind? Because there's everywhere in pathology I've taught you, as soon as I say glycogen, okay, a PAS should come. As soon as I say mucin, mucicarmine should come. As soon as I say fat, oil red O should come to your mind. So these are all the stains that should come to your mind when these words are spoken. Apart from that, I have to tell you, because you're dealing not just with Paget's. When I told you vulva, I only told you these 3 things. But when I'm talking about Paget's of breast, I have to talk about ER, PR and HER2/neu. Remember that Paget's, I have learned that Paget's is occurring in all these female things, like it's occurring in the breast, female, it's occurring in the vulva, female. So it's occurring in all female things. That is why I've only kept it HER positive. HER is positive over here. ER and PR are not positive. Okay, no ER, PR. ER, PR is negative and HER is positive. That is the, the hormone profile of Paget's disease. I hope it's okay with everyone. And the same story goes in vulva as well, but not in the bone. In the bone, it's totally different Paget's that you talk about. Now, done with all the tumors. My concern over here is that there are two tables that have been added, and that also is important when you go to surgery. So what is the first table? The table is how do you do the molecular classification in breast cancers. Before I go into, everyone's heard of these luminals, but before I go into this, the question that comes is, how was this molecular classification made? What was the basis of this classification? And that answer most students go wrong, because options mein likha hota hai ER, PR, HER2/neu. You say, yeah, everywhere in the table I'm reading ER, PR, HER2/neu, so that is the basis. No, that is not the basis. How this classification was formed was by gene expression profiling. The classification was made initially by studying a lot of genes and genetics by gene expression profiling. Later on, then they said that we need a simpler method to this gene expression was done at a research level. Then they had to make it economical and they had to make it applicable to the patient level, which could be done on a widespread population. So then they came out with what you can call as a solution to the problem, or you can call it a more economical solution, or in simple Indian language you call it jugaad. They said, let's find out something which is cheaper, faster, and easier to do at a widespread scale. And then they found out ER, PR, HER2/neu as a surrogate. So, I say that the initial molecular classification was based on genetics, but then the surrogate molecular classification, the surrogate is based on ER, PR, HER2/neu. So before we go into it, and before I start explaining this, how am I measuring ER, PR, HER2/neu? ER, PR, and HER2/neu is measured by that brown color stain in pathology. And what is the brown color stain? We all know it is immunohistochemistry. The brown color stain is immunohistochemistry, right? So firstly, have a look at this. ER means estrogen receptor, PR means progesterone receptor, and if you look at both of them, the nucleus is coming out to be brown over here and the nucleus is brown over here. So everywhere it's the nucleus that is coming out to be brown. Whereas when I talk about HER2/neu is something which is, oh, by the way, HER2/neu, do you remember in your neoplasia chapter, HER2/neu is also known as EGFR2 or ERB2. HER2/neu is also known as all 222 things. HER2/neu is known as EGFR2 and ERB2, all the 222 things coming. And this comes brown color in the membrane. So that is a question that you get. That, okay, which of them are nuclear? So we all know estrogen and progesterone receptors are nuclear receptors. So the brown color will be in the nucleus and HER2/neu is in the membrane. But now, there is a scoring that you have to do. How much? One cell is brown, will you take it positive or not positive? So remember, for ER and PR, we do a scoring called an all red scoring. There is an all red scoring which you have for ER and PR, and that tells you even 1% cells are considered positive. Even if one brown color nucleus you see, that is also going to be considered positive. So every cell counts when you're doing ER, PR. Whereas for HER2/neu, it's very, very interesting because there is a scoring system. And that scoring system basically tells us that if you get a score of 0 to 1, you will not call it HER2 amplified. It is considered as negative. 0 and 1 plus is considered negative. If you get a score of 2 and 3, now we are talking. Means if you get a score of 3, it is definitely positive. But if I get a score of this 2, I am kind of confused. I can't even call it negative for HER2/neu amplification. I can't even call it positive. So I will call this as equivocal, and I will have to do something else to prove my point. So coming to that again, if I get HER2/neu score 0 and 1, it's negative. If I get a score 3, clear cut positive. These are easy things. Means why am I trying to do this? Because think a little logically. When I'm trying to find out the protein, somewhere I'm trying to express the gene, right? So when I say HER2/neu is negative, you'll say, okay, HER2/neu is not amplified. You don't have to give HER2/neu therapy. But when I say it is 3 positive, HER2/neu is positive, what do you think you're going to treat the patient with? Anti-HER2/neu, you're going to treat the patient with trastuzumab. You're going to treat the patient with trastuzumab. So yes, that is how we have correlated this, that when the pathology report says HER2/neu is negative, I don't have to give trastuzumab. When the pathology report says 3+, HER2/neu is positive, I can give patient trastuzumab. But when the pathology report says 2 scoring, now where am I? I'm stuck. I will have to go for some other technique. This means this immunohistochemistry 2+, this is not going to help me. Now I will have to move ahead and take help of something known as FISH. So that is the protocol that you follow for HER2/neu. Everyone, I'll repeat it once again. It's very, very important. Whenever the pathology report says that on immunohistochemistry, the scoring is 0 or 1, negative, no drug therapy for HER2. If it's 3, positive, definite HER2 therapy. But if it's 2+, then after IHC, you will have to do something called FISH. And what do you do in FISH? I hope everyone remembers this same image because we had studied this once back in the genetics chapter as well. So what do we know about HER2/neu? Firstly, HER2/neu is present on chromosome number 17. So you know, what does the genetics expert do? Firstly, for chromosome 17, they tend to give a green color. For chromosome 17, they've given a green color. And for HER2/neu, they've given a red color. You don't have to learn these color codings. Color codings of FISH will always be given by the examiner. So whenever you're talking about FISH, the color coding is not decided. Today, if I want to do FISH, I will decide whom do I want to give a red color, what do I have to give a green color. So they have given you this color coding. So now tell me, for chromosome 17, they have given a green color. Think logically, how many chromosome 17s do you have? Every chromosome for that matter, you have in a pairing, right? So how many 17 signals are you expecting? I am expecting 2 17 signals. Yes, I can expect one over here and I can see one over here. So this is obvious. I can see a 17 here and a 17 here. So the first thing that I go and I see in a cell, everywhere am I getting a pair? Is everything normal? Okay, over here also 17, 17, normal. Over here also 17, 17, normal. Till the time I'm getting 2 17s, I'm happy. So first thing is pick up chromosome 17. Why are you picking up chromosome 17? Because on chromosome 17, you have HER2/neu. So now to HER2/neu, you have given a red color. So now think logically. If I have 2 17s, I should have 2 HER2/neu. Like, for example, over here, when I had 2 17 chromosomes, 17 and 17, I had 2 HER2/neus. I can see the 2 red colors, 2 HER2/neus were there, everything is fine. So 2 17 chromosomes, 2 HER2/neu genes, and I am sorted. But now in the next cell, I realize the HER2 copies are 1, 2, 3, 4, 5. Has HER2 become amplified? Yes, low level amplification has occurred. When I look at the next cell, I can't even count how many HER2 copies are there. It's impossible to count. There are definitely somewhere 10 to 15 or even more. Is this a high level amplification? Yes. So you will ask me now, after what point should I say HER2 is amplified? You have a formula for that. They say when HER2 upon CEP17 comes out to be more than 2.2. HER2 upon CEP17 comes out to be more than 2.2. That is when you say that HER2/neu is amplified. That is when you say that HER2/neu is amplified. So how did I calculate it? Can you do the calculation for me? Let's try making you do the calculation. HER2/neu upon CEP17. Always first count chromosome 17. How many 17s do you have? You have 2 17s. Denominator sorted. How many HER2/neus did you have? Approximately, if I count, I have like 5. I have 5 HER2/neus over here. Is this coming out to be more than 2.2? Yes. So is there an amplification? Yes. Over here, the next one, again, HER2/neu upon CEP17. 17 is always 2 in number. So I can see the 2 17s, but HER2/neu I can't even count. I'll assume they are 10 to 15. But whatever is it, let's say for example there are 10, it has to be more than 2.2 to call it amplified. So now guys, go back. Whenever you get IHC, the brown color, first you will always do the brown color because it's cheaper and easier to do. On the brown color, if you get a 0 or a 1, this means HER2 is not amplified. You don't have to do anything. You don't have to give the treatment to the patient. If it is 3, then it is HER2 is amplified. You don't have to do any FISH in any of these cases. Either it's a clear-cut negative or it's a clear-cut positive. I don't have to do FISH then. If it's a clear-cut negative, don't give the patient therapy. If it's a clear-cut positive, give the patient trastuzumab. When do I do a FISH? When I get a scoring of 2. When I get a scoring of 2, I will do a fish, and then imagine on a fish, if you would have got something like this, you would have got a level of more than 2.2, you will say HER2 is amplified. And if you would have got this, not a 2.2, just a normal situation, you would have said, no, HER2 is not amplified. Don't give the patient treatment. So the purpose of knowing HER2 amplification is ultimately trastuzumab, right? On that note, the HER2/neu testing is done, but where did this story actually start from? Why was I doing immunohistochemistry? Because I realized that they have a molecular classification of breast cancer, and in that molecular classification, I need to pick up the something cheaper version or a surrogate for a genetics. And there we started with this. Read it, guys. We have two luminals called luminal A and luminal B. Then we have a HER2 rich variety. Then we have a triple negative, and triple negative nowadays is also said to be the basal triple negative, the basal type of breast cancer. And I have three things in front of you, ER, PR and HER2/neu. Let's put a little bit of common sense. What will you have in triple negative? There's no points, no brownie points for guessing that triple negative will be ER, PR, HER2/neu, everything negative. What do you think is HER2 rich? No points for guessing again. HER2 rich is of course only going to be HER2/neu positive. So imagine you've got one category where only HER2 is positive. So then the ER and PRs are fighting that when will we become positive? So then you have two categories in which only and only ER PRs are positive. Such a simple table and students panic over it for no rhyme and reason. Remember, triple negative means everything negative. HER2 rich means only and only HER2 is there. So one category only for HER2. So this means there has to be one category for ERs and PRs. And those categories are known as luminals. But over here, isn't luminal A and B looking exactly the same? Should I do some differences? Yes. Sometimes luminal B can be HER2 positive also. In other words, can I say sometimes it can come across as a triple positive variety? So now you know triple negative was basal, all negative. But luminal B can sometimes be everything positive, sometimes, and that is triple positive. But what if it wasn't a triple positive? What if it was ER, PR positive, HER2 negative, just like a luminal A? Then how would I have differentiated? Then you will go ahead with a marker called Ki67. If Ki67 is less than 14%, it is luminal A. If it is more than 14%, it is luminal B. There's a lot of changes happening. Some people say the cutoff is 20%. All those changes will always continue to happen because breast cancer as a topic is evolving day by day. But your basic concept that you have to know is what is Ki67. Ki67 is known as the MIB1 labeling index. Ki67 is known as MIB1 labeling index. So that is going to tell me the proliferation. How much is a tumor proliferating? It's a proliferative marker. So now I think you can easily guess. I will not write it. This is for you to analyze, guys. When I'm saying Ki67 is low, means this is less proliferating. When I say Ki67 is more, means it's more proliferating. So put your common sense. The low proliferating tumors come in luminal A. The high proliferating tumors come in luminal B. That's your first classification. Now I'm going to link it with whatever we have studied up till now. We studied all the types. We need to fit it in. We studied genetics, BRCA1, BRCA2. We need to fit that also. So please remember, look at these types first. What all comes under triple negative? So NE for negative, and now we have ME things coming under it. So that is how I've learnt it, that when you say NE for negative, you have ME for medullary carcinoma breast and ME for metaplastic carcinoma breast. Easy. ME is NE. Now we come to HER2 rich. So HER2 rich has something called apocrine carcinoma. So she is happy to be rich. Of course, everyone is happy to be rich. Anyone gets money is always going to be happy. So we have learnt it as apocrine carcinoma. We have learnt it as apocrine carcinoma because she is happy to be rich. Happy to be rich. So HER2 rich is apocrine, happy to be rich. Okay. Now whatever is left after that, tubular carcinoma, mucinous carcinoma, papillary carcinoma, invasive lobular carcinoma, comes under luminal A. Does that make luminal A the most common out of all of these? Because it's somewhere become like a dustbin category. Everything is coming under it, right? So it is going to be the most common. Okay. Now, if I do a slight change, I know that luminal A was less proliferative, Ki67 was less than 14%, luminal B was more proliferative, Ki67 was more than 14%. So if I want to divide the invasive lobular carcinoma into a low grade versus a high grade, I can easily do that. A low grade is going to be luminal A lower because less proliferation. High grade will be luminal B because it's a higher proliferation. Easy to do that. I hope the table is easy. So now we'll repeat. Triple negative, NE for ME and ME, medullary metaplastic. HER2 rich, happy to be rich. So happy-crene, hapocrene carcinoma. Luminal A has everything else, but if I make anything high grade, that is going to go into the luminal B. So which is the most common out of them? It is going to be definitely the luminal A. Which is the worst prognosis out of these? The worst prognosis is going to be the triple negative. Now, this is what I correlated with the prognosis. What is the correlation with the genetics? Remember, we studied BRCA1 and BRCA2. So please remember, BRCA1 tumors are usually associated with triple negative. BRCA1 genetics with triple negative, and BRCA2 is associated with the 2,2 luminals. BRCA2 is associated with the 2,2 luminals. 2,2 luminals. So BRCA2 and 2,2 luminals, whereas BRCA1 is associated with triple negative. Having discussed the molecular classification, there's an update that has come up in the molecular classification, and that is the Claudin low. What is the Claudin low variety? It is definitely a type of the triple negative only. So this means that for a fact the ER, the PR and the HER2 neu, everything is going to be negative. But what additionally is negative is Claudin. The expression of Claudin is low, and on the basis of that they called it the Claudin low tumor. So now not only is ER, PR and HER2 neu negative, the Claudin expression is also going to be low, and like triple negative was very poor, Claudin low is also going to have a poor prognosis. That definitely wraps up our entire story of the molecular classification. Definitely these 2-3 tables are going to be very important, talking about not only their examples and their genetics, talking about how the cancer and the genetics, it is very, very important. Correlating this with the prognosis, with the therapy, with the IHC, with the fish, all of these points are definitely going to help you. Before I end, there is one more pathology related point that I want to tell all of you, and that is the modified Bloom-Richardson scoring. Again, something done by what? This is not the staging and grading that a radiologist does. This is the staging and grading that a pathologist does, and this is basically done on microscopic examination, the BR scoring, the modified Bloom-Richardson scoring. And what is the TNM? Sounds like TNM, but no, this is not the TNM that you guys do in your clinics. So TNM in clinics means what? In clinical size, it is the tumor size, it is the lymph node status, and it is the metastasis, right? I've kept the mnemonic TNM, but it is not tumor node and metastasis. T stands for tubule formation. I have to think of things which I'm seeing under the microscope. T stands for tubule formation. N stands for nuclear pleomorphism, or nuclear, how the nucleus is different shapes. So nuclear pleomorphism. And M stands for mitosis. M stands for mitosis. So repeating, T for tubule formation, N for nuclear pleomorphism, M for mitosis. That is going to be the TNM staging that you have for the BR scoring, the Bloom-Richardson scoring. With which we wrap up our discussion of the breast cancers. We are ready for some questions. I hope so, and let's move forward. There's a 30-year-old woman, and that woman has suffered a traumatic injury to her breast while playing soccer. Physical examination shows a 3 centimeter area of ecchymosis on the left breast. So there's a very classical history of trauma here. 2 weeks later, the patient feels a firm lump beneath the area where the bruise had been located, and which of the following is the most likely diagnosis? I realized that, okay, there's a firm lump, and a 30-year-old female, I can think of things like fibroadenoma, maybe a fibrocystic disease also, but what I have very, very classically mentioned over here is a trauma. And as soon as the history of trauma comes, I know I'm dealing with fat necrosis. And what is that firmness? Because fat necrosis shows you calcium deposition, and that makes that lump very, very firm or hard. So this was sorted. This is a case of fat necrosis. Moving on to the next question. Cancer detected in one breast, which to be screened in the contralateral breast also. What cancer am I talking about? If it's found in one breast, you have to screen it in the contralateral breast. So that cancer is, of course, invasive lobular carcinoma. Invasive lobular carcinoma tends to be bilateral as well as multicentric. Let's pick up a next question. The only breast tumor to have the same incidence in males as well as females. Otherwise, all the tumors were more common in females, right? But this is the only one which is having both equal preponderance of male as well as female. So, male equal to female was myofibroblastoma. And I had given you a way of learning it, that God has only given it M and F both. Myofibroblastoma, male, female both. Picking up the next question. There's a 30-year-old female who's presented with a 4 centimeter mass in the right breast. The biopsy shows densely packed cells with bland nuclei and mucin infiltrating the stroma. As soon as the word mucin comes and I see this picture which is showing me pools and pools of mucin, I know for a fact that I'm talking about mucinous carcinoma, and mucinous has been given another name, that is colloid carcinoma. Can be soft to firm, can be mistaken clinically, but it's very, very important to know it from mucinous point of view. Let's pick up 2 more questions. There's a 24-year-old female who presented with a painless left-sided breast lump for the last 2 months. Local examination has shown soft, mobile, non-tender mass. Mobile, something in a young female which is a mobile mass, a lump in the breast. I will always start thinking of query breast mouse. Maybe it's a fibroadenoma. Excision biopsy was done and the histopathological image is shown below. What is your diagnosis? What is the histopath showing you? It's showing you those compressed ducts. See, the clinical and the histopath both is going in favor of a fibroadenoma, isn't it? But now, which kind of fibroadenoma is it? Is it intracanalicular or pericanalicular? We had studied that anything that's looking like eye, that is going to be intracanalicular fibroadenoma. The ducts are compressed. They're looking like an eye. If they would have been open like a pea, I would have called it pericanalicular. But right now, they are compressed like an eye. So it's intracanalicular fibroadenoma. Let's pick up the last question before we wrap up this session. Radiation-induced breast cancer is associated with, so again, as I said, you have to keep what on radiation? You have to keep a check on radiation. So check 2 is what is associated with radiation-induced breast cancer. Yes, that is again an expected question, and that also wraps up not only your discussion of breast cancers, but the entire breast pathology chapter comes to an end. It would ideally be, an ideal situation would be when you revise this alongside with surgery and finish off the treatment modalities also.